Omara González Lozano. I work as a radiology resident at the Rivera Povisa Hospital in Vigo, Galicia, Spain, and I would like to discuss an interesting case we had very recently, and that I have prepared together with my specialist colleagues in chest and neuroradiology. This was an 83-year-old man who fell from a staircase and hurt his back. He went to the emergency room and underwent a chest CT scan, where a fracture of the vertebral body of T10 was observed, with both fluid and gas present inside, associated with Camille disease, or a sign of vertebral body vascular osteonecrosis. Such findings are common in patients with osteoporosis, who use corticosteroids or radiotherapy, or alcohol users. Also, ossification of the anterior longitudinal ligament was observed in relation to diffuse idiopathic hyperostosis, and there was also a fracture of the laminae of TIX. He had a right-sided pleural effusion associated with a hemothorax. It is worth mentioning that the aorta was normal in this case study. No issues were detected. 3 months later, he went to the emergency room due to an episode of intermittent loss of strength in the lower limbs, with an inability to stand, and he has no feeling in his legs while he was lying down. It was partial recovery, and during the consultation, he exhibited only weakness. He had an increase in back pain that started immediately after his fall, and struggles to recall the last few days. These are his personal medical history, and during the physical examination there were no specific findings. It was decided to admit the patient to internal medicine, and the following tests were requested, where a posterior cord pathway involvement from the lower limbs was highlighted in the somatosensory potentials. Additionally, a full spinal MRI was requested, revealing fractures at T9 and T10 levels, and an injury affecting the posterior ligament complex in this area. But the key point is what I marked with the asterisk, which refers to a sign of the descending aorta, for which it was advised to conduct a focused study. An aortic angiogram was requested, performed without contrast in the arterial and venous phases, where we can already see that in front of the gas observed in the vertebral body, there is a involvement of the thoracic aorta. Here we see the study without contrast more closely, where we see a lesion with a semi-lunar morphology with hyperdensity concerning the lumen of the aorta, which results in the intimal calcium being pushed inward into the lumen. The location of the intimal calcium is very helpful for diagnosing the pathology observed. When we use contrast, we can see that this lesion does not fill with contrast, and in a sagittal plane, we can observe its relationship with the fracture of the vertebra already known. If we look at the CT from 3 months earlier, we can observe that currently there is a greater amount of gas inside and also a partial collapse of the body of the vertebra, which has lost some height. It is also worth noting that the patient showed a decrease in bone mineral density suggestive of osteoporosis. And furthermore, upon closer inspection, it was observed that there was also a gas bubble inside the wall of the aorta. Therefore, we are facing an acute intramural hematoma located in the descending thoracic aorta type B, according to Stanford, as a result of the laceration caused by the compressive fracture of the T10 vertebral body. The patient's evolution was good, remaining stable without complications or new symptoms, leading to hospital discharge with conservative management, with strict control of blood pressure and follow-up in outpatient department with angio-CT controls. Thus, in our daily clinical practice, most of the time when we see an acute aortic syndrome, it tends to be of spontaneous etiology. Traumatic etiology is usually associated with traffic accidents or high-impact trauma. But sadly, these patients frequently do not arrive to the hospital because of their high mortality rates. While it is true that aortic injuries secondary to vertebral fractures in our clinical practice are rare and have high mortality, there are 3 types of vertebral fractures. According to the AO spine classification, there are 3 types of vertebral fractures. Fractures can arise from compression, distraction, or translation depending on the mechanism. The types most frequently associated with aortic injury are type B and type C, especially type C, which are the most severe. And in most cases, literature shows that both vertebral and aortic damage is located at the thoracolumbar level, at the level of T11 and L2. In our case, the fracture was at T10, but the intramural hematoma extended from T10 to T12. And it is important to remember that in patients with fused spines, such as our patient with diffuse idiopathic hyperostosis, and also in patients with ankylosing spondylitis or severe arthritis, there are significant adhesions between the anterior longitudinal ligament and the aorta. And in cases of distraction or translation fractures, there is a higher predisposition to aortic rupture, traumatic. Therefore, in an appropriate clinical context, one must be alert and suspect it. In the case of our patient, it was caused by a compressive fracture, where the mechanism involves small fragments of the anterior wall that shift toward the aorta and lacerate it. And finally, it is important to note that vascular repair must always be done prior to stabilizing the spinal column, as doing it the opposite way could pose significant risks and result in the death of the patient. Here show you 2 very interesting articles that discuss this topic. And thank you very much for your attention. I hope you enjoyed the case, and here is my email.